Hello, my name is Daniel Sperling and I'm a faculty member at the Department of Nursing at the University of Haifa in Israel. Now I would like to share my PowerPoint presentation with you. The significant and rapid spread of COVID-19 around the globe has had an enormous effect on people's well-being, health, and economy. When managing this dynamic and new pandemic, healthcare providers, especially nurses, face the gravest and most complicated challenges and opportunities. Positioned at the front line, nurses fight the disease at their own personal risk of infection for themselves, their families, and others with whom they may come into contact. The more widespread the pandemic, the more serious its implication, and in turn, the more intensified the required clinical care. As a result, nurses have to accommodate new protocols, work long shifts, and deal not only with patients, but also with their remote family members. A lack of medical resources and protective equipment for medical personnel, combined with the shortage of nurses during pandemics as a result of quarantine, also makes nursing care a difficult and challenging task. As a result, nursing care in times of pandemics is extremely stressful and demanding and is frequently associated with anxiety and anger. Such negative experiences may be related to reduced level of resilience and burnout, and as such may increase nurses' intentions to leave the profession. The emergency nursing scope and standards of practice provides ethical guidelines to emergency nursing. It stipulates that the nurse's primary commitment is to the patient. However, it also states that the emergency nurse has a duty to apply self-awareness and self-care when promoting self-health and safety. As emergency care settings may be stressful, the code states that nurses have a personnel and a professional obligation to learn and develop strategies for promoting resilience. Importantly, it further emphasizes that work-life balance is paramount for achieving personal growth, whereby structures and processes that enable such a balance are required. These include shift preferences, time off, means for enhancing personal satisfaction, the receipt of compensation for ensuring financial security, reading to develop a creative mind, and ensuring leisure and recreational activities. In line with these guidelines, nurses express various concerns during outbreaks of infectious diseases, with a focus on organizational and social support. For example, a study of 100 Canadian nurses following the SARS outbreak found that nurses fear they may infect their loved ones and feel guilty about that. However, if they choose not to work in such a situation, then they feel guilty towards their co-workers. Nurses also discuss the need for them to hire someone to take care of their child, the elderly family member, or pet when they are required to stay at work. They also emphasize the need to find time for communication with their families during long shifts or quarantine. Providing healthcare services during the COVID-19 pandemic gives rise to serious ethical and organizational tension and dilemmas. Moreover, managing them is central to the job satisfaction and work motivation of nurses, and equally important to their overall well-being, affected by their relationship with the family or a loved one. The conceptual framework for this research holds that the decision on whether providers will stay and carry out their duties in times of emergency depends on, first, nurses' values, especially their obligation to provide unconditional care, religious beliefs, personal motivation, and personality-based values. On, second, professional and social considerations, including the fulfillment of public expectation and trust, augmenting community welfare, considerations pertaining to their co-workers, training and status, and their duty to help those in need, and third, on their own risk assessment. The research examines the following question: how do Israeli nurses respond to ethical tension and dilemmas during the COVID-19 outbreak, and to what extent are their responses related to their protection of risk and perception of risk and their motivation to provide care? The research utilized a 53-question questionnaire. The first 19 items examine work-related and socio-demographic characteristics, having COVID-19 guidelines in the units, and being in close contact with someone who is considered high risk for contracting the virus. For the second part of the questionnaire, respondents rated the extent to which they agree with 18 statements related to the nurse's sense of confidence when caring for sick or carrier patients, ethical dilemmas relating to providing care during the pandemic, their compliance with guidelines, and so forth. Next, respondents were asked to rate the degree to which they perceive themselves as being at risk for contracting the virus. In the fourth part of the questionnaire, the participants were presented with 9 statements representing ethical questions and dilemmas during the pandemic and asked them to rate them. Finally, respondents were asked to rank motivational factors relating to working in the health sector during the COVID outbreak and their importance. In addition to these closed-ended questions, the questionnaire included 4 open-ended questions related to the respondents' descriptions of their work, fears and concerns, and tasks and assignments that they have been asked to perform during the pandemic. This talk will present the analysis of the full questionnaire, excluding the open-ended questions. The full article has been published recently in Nursing Ethics. After a pilot test of the questionnaire in which 50 nurses participated, a link to an online questionnaire was posted on a WhatsApp group and on 18 Facebook groups for nurses, which led to a snowball sampling of healthcare professionals in the nursing community across Israel. The study began on April 13 at the height of the COVID-19 outbreak in Israel and ended on May 9th, when the dedicated COVID-19 wards in major hospitals in the country began to cease operation following a significant decrease in the number of newly diagnosed patients. Various tests were used for conducting inferential statistics, and they are mentioned here. The qualitative data achieved from the study via open-ended questions was stored and analyzed using Atlas software, and conventional content analysis was conducted. Of the 430 questionnaires submitted online, 231 had been completed correctly and were fully analyzed for this research. The research sample was representative of the nursing population. It was predominantly female, Jewish, and Israeli born. The mean age was 41. The majority of respondents were married and secular, with an average of 17 years education and 14 years of work experience. Most respondents were registered nurses from various fields of specializations and who worked in several departments, mostly in government or public hospitals. On average, when asked how they perceived the risk for themselves contracting the COVID-19, the respondents positioned themselves at a relatively high level of risk. Mean was 6.2. on a scale of 1, which means no risk at all, to 10, very high risk. Moreover, more than 32% ranked the risk of their contracting the virus as very high, at the level of between 8 and 10. Nurses who work in intensive care, internal medicine, or corona departments rank their risk perception higher than other nurses. Moreover, the higher the education, the higher the perceived level of risk. Registered nurses ranked their perceived risk higher than intern nurses. 43% of respondents stated that they were in contact with high-risk people in both to their families and their workplace. Moreover, more than 28% of respondents highly agreed with the statements that they fear coming to work because of the risk of contracting the virus, and 36% highly disagreed with the statement that they feel protected in the work environment. The higher the nurses' perceived level of risk, the more they fear coming to work. Moreover, the more educated the nurses, the less they fear coming to work because of potential risk. Nurses who work in units which have clear COVID-19 policy guidelines are less afraid to come to work than nurses who work in units that do not. Finally, nurses in private hospitals fear coming to work more than nurses in other work environments. A large percentage of respondents, more than 40%, greatly agreed with the statement that they are scared to care for sick or carrier patients. This is consistent with an additional finding whereby 41% of respondents highly agreed that caring for sick or carrier patients entails a significant emotional burden. Moreover, an even higher percentage, 46% of respondents, highly agree that caring for sick or carrier patients will keep friends or family members away from them. Almost 33% of respondents highly agree with the statement that if they have a choice between caring for a diagnosed or suspected COVID-19 patient or someone who has a different medical condition, they would prefer to care for the latter. The average maximum age of patients who would receive care if such a decision had to be made as a result of medical scarcity was 84. Note that almost 70% of respondents referred to the range of age between 80 and 99. 80% of them refused even to give an age limit, rating either 0 or 120. Furthermore, with regard to possible cases of resource shortages, while most respondents did not think that older patients should be connected to respirators, a large majority, more than 60%, did not think that older patients should be disconnected them from such machines once connected. A large majority, more than 80%, believe that all patients have a right to equal optimal care during pandemics, regardless of their age and medical background. Similarly, most respondents, more than 70%, did not think that patients who are responsible for their medical condition, such as smokers or people who did not take protective measures, should receive less priority for treatment compared to other patients in time of shortage. The more the nurses felt confident and competent to treat these patients, the less they felt that they had a right to refuse treatment of selective patients. The more the nurses feared treating sick or carrier patients, the more they believe that they have a right to refuse to provide treatment. The more religious the respondents, the less likely they are to agree that older patients should be disconnected from ventilators for the sake of younger patients. On a 1 to 5 scale, respondents expressed minimal agreement with statements that COVID-19 increases their consideration of attrition, prevents them from embarking on the nursing profession when applicable, and increases their desire to move to another position within the nursing profession journey. Similarly, they greatly disagreed with statements that COVID-19 outbreak has made them regret choosing the nursing profession. The three most frequently mentioned motivational factors for working in the healthcare system during this outbreak were respondents' accumulated knowledge and skills, obligation to treat patients, and the need to make a living. However, the most important motivational factors included respondents' obligation to treat patients, followed by their obligation to provide help to the Israeli society and the need to make a living. The study reflects the conflict between nurses' commitment to patients and society and their right to self-care during the COVID-19 pandemic. In light of their increased risk for contracting the virus, and as with any pandemic, nurses have to decide how much care they can provide others with while taking care of themselves at the same time. While provision of care at this time is highly stressful and is accompanied with personal risk, they do not regret choosing nursing as their profession. They seem highly motivated and are mostly influenced by their obligation to treat patients, and interestingly, also by their obligation to provide the Israeli society with help. These findings are in line with previous research on the willingness of Israeli nurses to work in times of emergencies. Yet nurses' fear of coming to work and caring for sick or carrier patients with minimal support are significant sources of anxiety and key concerns. So in conclusion, nurses' clinical competency during this pandemic is mutually interrelated by their relationship with their employers and family, as well as by their concerns relating to their own personal protection from the virus and their general attitude toward the pandemic. Employers and health managers should employ strategies from promoting work conditions to allow a better fit between nurses' personal needs and their work demands in times of pandemics. The lack of ethical climate and institutional support combined with the disrupted work-home balance constitute a serious threat to nurses' careers and overall satisfaction from their career choices. This research emphasizes that other than providing nurses with a safe work environment during pandemics, it is of great importance that nurses feel their voice matters and that their rights are respected, much more than in routine medicine. Nurses deserve full care and support within their organization so that they could thrive and offer the best care while feeling happy and proud to fill this position. Thank you very much, and you can also read further my full research in this article.